Good afternoon, everyone. I'm here not because of what you see in my bio, and not that he said that I'm Professor Emeritus. Dr. Lynn and Dr. Norwood are here as the GW academics. I am here because I spend most of my time at George Washington seeing doctors, and not the ones that I would normally see on rounds or in the clinic or with a patient for teaching purposes. I am here because I am a patient. I am a patient who in the future might want to use the Medical Aid in Dying program. I have worked a very long time with Compassion and Choices to introduce the program in the States. And I began with Catherine Tucker, a lawyer, who was very active in the early 2000s. And at that time, I remember our speaking to the Public Health Association, which wanted nothing to do with such a radical idea, but has since evolved. In the American Medical Women's Association, a survey was done to ascertain the opinions of our members who voted well over 50% to support the idea. We had a position paper in 2003 to that effect, whose revision time is soon. Some medical organizations leave these controversial topics to their boards, which may or may not represent the body as they think. They then present the board's view in a journal or a newsletter as if it is the will of the body and it gets perpetuated. And that can be either for or against or neutral. Today and yesterday, you talked about the ethics of such a program and the logistics of those in practice in the 5 to 7 states. And I say 5 to 7 states because DC has it, but we haven't really implemented it. I don't think any doctor has participated or patient yet, where it's illegal and has worked very well without problems. Oregon has a 20-plus year experience. And I hope you have delineated any dilemmas you have uncovered and will therefore offer the solutions to the medical community. I also hope that you have considered that quality of life is a very personal topic that should be discussed between the patient and the physician, who hardly has time to solve the chief complaint of the patient, and many times is fighting burnout in a very real sense. I very much want to emphasize that the program is voluntary and must be assessed by a patient who is competent and has obtained consultations from at least 3 doctors. I say 3 because most of us are going to have a private medical doctor, and then we have to get the 2 consults. And then obtain prescriptions for the medication from his or her primary care physician. And I'm not even sure that my primary care physician would even do it. I haven't even discussed it with him yet, but I will discuss it with him. Purchase the medication from the pharmacy and is able to take the medication without help. Many patients get the medications and do not use it. Some get the prescription and do not fill it. But anyone within 6 months of dying in a state where the program is legal can avail themselves of the help. Dr. Lynn discussed the difficulty of predicting when dying will occur. All of us know patients who have decided that the analgesics and other medical aids are no longer adequate in the hospice or palliative care programs that are available. I want to have that program of medical aid in dying available in my state in case I want to use it. In the past 3 years, I have lost very good friends, all in the medical field, to cancer. One was a geriatrician who looked up at me and said, "Omega, this is taking too long." I know she would have used the program as we had discussed it many times. Wouldn't it have been wonderful if she could have said, "Omega, I think I'm ready, and I'm going to get my pills"? Unfortunately, I have a few other friends living with cancer who might want to access the program as well. I do want to suggest that the subject of death and dying is a topic that physicians could learn to diagnose and treat better. They should have a facility with the patient discussion and be able to provide guidance in the course and resolution. We should have an early introduction to the concept of death in medical school, in the medical school curriculum, an easy referral to those topics throughout specialty training and into practice, including hospice and palliative care. Physicians don't like to talk about death, and they're terrible at it. They walk into the patient's room, talk to the patient for 5 seconds, and run out. They don't want to stay there. They don't have, and then in many instances, they don't have time because you have 10, 15 minutes with a patient. So you don't have time to get into a discussion about things like that unless you really make it part of the way you treat your patients. So that's what I would like to say, and I hope that we will expand this program because only people who want to use it, use it. Nobody is forced to use this program. And I will make one comment about African Americans. In DC, we paid special attention to the African American population, and we called in many African American groups. And of course, we had to deal with the Tuskegee incident. But what we said was that this is a voluntary thing, and you can do it or not do it. No one is going to force you to do it, whether you're Black, Hispanic, green, purple, or whatever. So that's the way we approached it here, and I think that's the way we'll have to approach it in other states where there is some diversity. Poor Colorado, no, Oregon is a pretty white state, so we don't have to worry about it there. But there are plenty of states, especially in the South, that are very much other colors. Okay, thank you.